Welcome to Lecture 6 of the Cardiovascular section for Integrative Systems Physiology. Today we'll be talking about ventricular preload, afterload, and pressure-volume relationships and pressure-volume loop depictions of cardiac function. So during our last lecture, we focused predominantly on the depictions that are shown in the full Wiggers diagram. Again, it's expectation that you should be able to draw this and accurately depict both the Wiggers diagram in health as well as in stressed or disease states. But today, we'll be changing gears a bit to say, well, what are some of the physiological implications of these changes in volume and changes in wall thickness in the context of ventricular preload and ventricular afterload? And so we'll start off just largely by throwing out two definitions, one of which is preload, which really relates to cardiac diastole, and the second is afterload, which really most closely relates to cardiac systole. So when we're looking at preload, I think we could probably put out three definitions initially for us to just work through and think about. So when we look at Wikipedia, the current know-all and be-all of most things, you say, well, how does Wikipedia define preload? And so here you can see that it's defined as the end volumetric pressure that stretches the right or left ventricle of the heart to its greatest geometric dimensions. One potential definition. The second could be from Guyton and Hall, a very commonly used medical physiology textbook, where you can look at it as the end diastolic pressure when the ventricle has become filled. In some ways, that would make sense when you're trying to assess preload or how much, quote, filling you have in the ventricle. And the third is the definition by the textbook that we use in our course, which is Boren and Bullpup, which is both initial sarcomere length, so how much the sarcomeres have lengthened during that diastolic phase, and end diastolic volume, so the overall volume of the ventricle, are measures of preload. So there, we'd say, well, maybe one of those is sufficient, maybe they're not, and so I think perhaps the biggest question is, well, why is preload important to understand and define accurately and appropriately? So there is a cardiac length tension relationship that is pivotal to the intrinsic regulation of beat-by-beat cardiac output. And so this is depicted here when we're looking, for example, at muscle sarcomeres or muscle fibers. And so we have depictions of skeletal muscle here. So we've got sarcomere length and the percent of maximum active tension. You can see that with skeletal muscle, there's a very broad range over which you can generate tension, but at very short lengths, you can't generate tension very well, nor at very long lengths can you generate tension very well. And that makes a lot of sense for anybody who's lifted some weights at some point. If your arm is very lengthened, you're kind of weak out here, and if it's really short, you can't really generate much tension there. Now, but at that sort of midpoint, that sweet spot of optimized overlap of actin and myosin and these thick and thin filaments here, that is where you can really start to generate your maximum amount of force. And very long, you don't have the optimal overlap. Very short, again, you've got that collision of certain parts of the ultrastructure of the sarcomere. So now, interestingly, when we look at cardiac muscle, you can see here that we have this active component here. So this is showing that there's a much steeper relationship. So as we increase sarcomere length, we can very dramatically increase force generation or tension generation in the sarcomere. And then suddenly when we get beyond a certain point, we have a very precipitous fall in tension that can be generated by the cardiac sarcomere. Now, importantly, when you look at passive cardiac tension as well, you can see here that relatively short sarcomere lengths, that tension generated passively is very low, but then once we get up above 2.2 microns or so, that suddenly we get an exponential increase in passive tension that's generated with increases in sarcomere length. And of course, these increases occur very dramatically around points beyond which we have losses in active tension generation. So you can say, well, this makes some sense, right? Because what you want to be able to do is you want to be able to optimize how much force your cardiomyocytes can generate and your sarcomeres can generate. But if you start to get to this point where you might be a little bit too preloaded, if you will, or too stretched, the passive structures of the ventricle and the passive tension generated by sarcomeres will prevent you from being overstretched and ultimately having very dramatic losses in force generation over the course of a cardiac cycle, which ultimately would simply propagate very rapidly over the course of subsequent cardiac cycles. So this is very important to just demonstrate that as we increase length of a sarcomere within reason, we will have a very robust increases in force generation over physiological lengths of the sarcomere. So when we look at this and extrapolate this from the isolated sarcomere to the heart, we would say, well, as preload is increased, however we want to define that, the pressure that is generated during the subsequent cardiac cycle will also be increased. And so here you can see here that with increases in diastolic tension generation or potentially preload, that we have subsequent increases in systolic tension generation and the ensuing cardiac phase. So again, we come back to the question of what's our best measure of preload? Is it potentially left atrial pressure? So at the end of diastole, right when we're having that atrial kick, is the pressure that's generated during that atrial kick and at the final point of filling, is that a good measure of ventricular preload? Well, the problem there is that left atrial pressure and any pressure that's measured within the heart might not actually translate to a volumetric change based off of the compliance of the ventricle and the pericardium, or the sac around the left ventricle, that might alter compliance and ultimately not have an accurate representation of the relationship between volume change and pressure change. Potentially, you could say, well, maybe left atrial pressure is bad, but maybe left ventricular and diastolic pressure is a little bit better. Well, you could say, well, it is a little bit better, but it suffers the same limitation as what you would see with left atrial pressure. And if we think of what you say, well, fine, I'll just abandon pressure altogether. Well, I will focus instead on end-diastolic volume. The problem with focusing on volume in and of itself is that end-diastolic volume does not account for the changes in wall thickness that we discussed at the end of the last lecture in the Wiggers diagram that occur at different cardiac volumes. And so what we would argue for is that the best measure of preload is actually likely to be a measurement called end-diastolic wall stress. And so wall stress in the central circulation is defined by this equation, which would be delta PR divided by 2T. So delta P is the transmural wall pressure, so that intraventricular pressure minus the extraventricular pressure or the juxtacardial pressure right outside of the ventricular free wall. That times the radius of the ventricle divided by 2 times the ventricular wall thickness. And so if we take a look at how wall stress actually would be calculated and the implications for the appropriate calculation of wall stress and preload within the ventricle, you can see here that with wall stress, we've got an increase in left ventricular volume, just as an example, from 92 mils to 125 mils at the end of the diastolic phase. So if we just used a volumetric estimate of left ventricular preload, we would say pretty simply that's about a 30% increase in left ventricular volume, or an increase of 30% of left ventricular preload. It's an increase in the radius of roughly 11% if we assume that the ventricle is relatively spherical. And subsequently, when we take a really close look at these pressure-volume relationships, we say, well, we can get an increase in left ventricular and diastolic pressure from about 5 millimeters mercury down here to about 10 millimeters mercury. All right, so we're going from 92, which is somewhere around here, to 125, somewhere around here. So it's a pretty subtle increase in left ventricular and diastolic pressure. So similarly, that's also going to reduce thickness of the ventricle based off of a ballpark of some of these images of about 10%. So now when we take our wall stress example of preload, plug these numbers into that equation, you can see that we have at baseline a level of preload that is approximately 7 units. And what we see with the increase in preload is we get an increase to about 17.2. And so when we take our volumetric estimate of what we would have had with preload, that we would have said, well, it's about a 30% increase in left ventricular preload. But when we take the wall stress as an example of estimating preload, now what we would see is it's roughly a 140% increase in the amount of stress that's generated in that left ventricular free wall. And so actually what we have is a dramatic and disproportionate increase in, quote, preload, stretching, filling, however you want to define that, but ultimately that being a more reliable and predictable estimate of the amount of preload being placed on the left ventricle or right ventricle during that diastolic phase. So when we ask the question now, so what are potential mechanisms regulating this phenomenon of having an increase in preload and a subsequent increase in tension generation? So the heart fills a little bit more, the heart contracts a little bit more. One mechanism is an increase in calcium sensitivity. So you can see here, even in isolated cardiac sarcomeres, as we have increases in cellular calcium here, you see we increase calcium. Of course, you'd expect there to be an increase in force generation because of increases in calcium-induced calcium release, as we discussed previously. And even when we're looking at under control conditions, as we get progressive increases in calcium, we get very nice increases in force generation under control conditions. If we shorten that cardiomyocyte a little bit or that sarcomere slightly, then what we see is we see at any at that shorter length, at any given level of calcium, we have a lower amount of tension generation. Similarly, if we stretch the cardiomyocyte more, we can see now with a higher level of, quote, preload, what we would have is a greater amount of tension that's generated at any given calcium concentration or any degree of calcium-induced calcium release. So there again, this isn't about necessarily an increase in calcium bioavailability within the sarcomere. Here we're saying, well, at a given level of calcium and calcium-induced calcium release, that we will have a greater amount of tension generation if that cardiomyocyte is stretched slightly more. And so you might say, well, that's fantastic, right? It looks like the larger my heart gets, the more filling that I have, the more preload that I have, the higher my stroke volume is going to be, the higher my maximum cardiac output is going to be. And that broaches the question, well, with preload, can you actually get maybe too much of a good thing? And so this has been discussed for a long time, and one of the key observations that was made many years ago was the potential for a descending limb of what's called the Frank-Starling curve. And so what's probably most accurately depicted is, even compared to the previous slides that we've discussed, is if you're looking at initial myocardial fiber length or some measure of preload, you can see when this increases, we have subsequent increases in the force of contraction. And so we increase myocardial fiber length, a little bit more force generation. Similarly, increase it further, we get some more force generation. Now, of course, there is a point, apparently, of diminishing returns where we end up having very dramatic increases in myocardial fiber length and a subsequent decrease in force of contraction during that subsequent systolic phase. And so that begs the question, well, it would appear as though you can get too much of a good thing. And this descending limb of the Frank-Starling curve was first observed by Starling in 1914. And so here, it's been postulated on many, many occasions that patients with heart failure appear to be operating on what would be a descending limb of the pressure volume of this Frank-Starling relationship. Because patients with heart failure, they generally, if they've had an infarction, they have a very large dilated ventricle. But despite the fact that this is very dilated, they also have a very low stroke volume. right, and a relatively low cardiac output. And so the argument there was that they were functioning on this descending limb of the Frank-Starling relationship. And you can see that this is just depicted here with what is commonly measured and was commonly measured in the 60s and 70s, measured very invasively using left ventricular end diastolic pressure. So you can see that patients were observed to have very high end diastolic pressures, very low stroke volumes and cardiac outputs. And so that begs the question, well, are they operating on this descending limb? And the reality is that they are probably not, right? And I would firmly believe that they're not, because absolute left ventricular end diastolic pressure does not reflect transmural wall pressure. And so when we have this dissociation, again, between pressure and volume, or pressure and a very reliable measure of preload, that it becomes very problematic with regards to characterization of a pressure-volume relationship. So even when you look back at the original work that was done by Frank and Starling, that you would say in Starling's original manuscript, he noted that producing a descending curve in isolated hearts produced profound ultrastructural damage that in general precluded further experimentation on that specimen. So there, yes, you can fill a heart up to the point where there is a reduction in force generation. It just so happens that you destroy the preparation. And of course, that is very consistent with in vivo saying, is there a descending limb? Well, if you're getting filling to the point where you're having destruction of the ultrastructure of the ventricle, that's probably not consistent with maintenance of homeostasis in any sort of way, shape, or form. And so it's very unlikely that you're going to be functioning at a descending limb without having just a very rapid physiological decline and ultimately death. So there, again, our argument with preload is that preload is best estimated by wall stress, best incorporated by ensuring that you're measuring intraventricular, pericardial, or extraventricular pressure, wall thickness, and an estimate of radius or dimensionality of the ventricle. But now let's shift gears a bit. Then we'll say, well, what about afterload, right? So we've talked about filling. Well, what about contraction? And how do we estimate how much work the ventricle actually has to do during that contraction phase to eject blood out and into the circulation? And so again, we can visit our options for which definitions of afterload might be correct. So of course we can turn to our trusty Wikipedia, where afterload would be defined as the tension or stress developed in the wall of the left ventricle during ejection. We can turn to Guyton and Hall, and Guyton and Hall they would say that the pressure, the afterload would be estimated by the pressure in aorta leaving the ventricle. And Boron and Bullpup would articulate that the afterload is best estimated by the force that the contracting cardiomyocytes must overcome. So an awfully broad definition of afterload. I would have to say this is a pretty sad day in physiology when we've got Wikipedia having what I would argue is the most accurate definition of ventricular afterload, where it is the tension or wall stress developed in the wall of the left ventricle or right ventricle during ejection. And so if we look at these other definitions with both Guyton and Hall and Boron and Bullpup, I think it's accurate to say that they're certainly estimating components of afterload, but those components in isolation result in a very oversimplified view of what work the ventricle actually has to perform when it's ejecting blood out into the central circulation. And then that stress ultimately has, and the measurement of that stress has implications for how the ventricle adapts both physiologically and pathophysiologically to chronic increases in stress. So that broaches the question, well, why is it so important to accurately calculate and estimate and understand afterload, right? Why can't we just take these components? So it's incredibly important in a variety of pathological situations. If we look at hypertension or heart failure, afterload is the primary determinant of the ability of the heart to both adapt over time and maintain homeostasis. And of course, it is an important determinant of ventricular adaptation. So you will have hypertrophy over time, and you can have beneficial hypertrophy as you would have with exercise, or you can have pathophysiological hypertrophy with chronic increases in afterload. And so really important to really grasp that appropriately. And so if we take a look back now and we say, well, what are our best measurements? Again, we'll take our end-systolic wall stress now. So instead of being at end diastole, we will now estimate afterload as being at end systole, so right at that period of time prior to the dissipation of tension during the phase of end systole, so the isovolumic relaxation, immediately prior to that, not when pressure is decreasing, but as soon as the aortic valve closes. You can see that, again, we've got wall stress being delta PR divided by 2T, so that transmural wall pressure gradient, the radius of the ventricle divided by 2 times the ventricular thickness. And so if we take an example now of abruptly increasing aortic pressure by 10 millimeters of mercury, so perhaps maybe in that period of time near end systole, right before the valve closes, we increase pressure by 10 millimeters of mercury, and you say, well, what happens to ventricular afterload? And so what would happen is you'd have an increase in left ventricular end systolic pressure from roughly 100 millimeters of mercury to 110 millimeters of mercury. So that is just the step increase in aortic pressure. Of course, you say, well, how would you do that? Many people have done experiments like this where they place a balloon in the aorta, or they inject fluid into the aorta, or they have a cinching mechanism in the aorta where they cinch it down very rapidly to increase aortic pressure in experimental animals. And so that's going to result in an increase in left ventricular end systolic volume from about 50 mils to about 55 milliliters. And again, taken from the picture of the pressure-volume relationship to the left ventricle during systole. Now that's going to be roughly a 10% increase in left ventricular end systolic volume, an increase in radius, assuming that it's a sphere, of roughly 3%. And so when we plug these numbers into our equation for wall stress, what we end up having is a baseline measurement, assuming that pressure outside of the heart at end systole is negligible, that we have a baseline measurement of roughly 88, so far greater than what we observed during the diastolic phase. But when we look at the increase in end systolic afterload now, it goes up with that increase in 10 millimeters of mercury. What we have is an increase in afterload going up to about 104. If you recall before, even during diastole, with the increases in volume that we had there, going from 92 to over a little bit over 100, there we had an increase in pressure of about 5 millimeters of mercury, right? And that increase in 5 millimeters of mercury, given the compliance of the ventricle, resulted in much larger changes in preload. Here, interestingly, with a relatively large and even almost doubling of the increase in pressure experienced during the systolic phase, we get a relatively small increase in the amount of afterload that's experienced at the ventricle. So we get a 10% increase in blood pressure and about an 18% increase in afterload, right? So not before we were, at about a 30% increase in our volumetric estimate, leading to a 140% increase in preload, right? A similar change in pressure resulting in a much smaller increase in afterload. And of course, it's very important because what you don't want to have is you don't want to have a very small increase in pressure, 10 millimeter mercury increase in pressure, and then just have the heart to say, well, I can't do it, right? It's too large of an increase in afterload. And so when we start to look at the integration of preload and afterload into these pressure volume loops and the adaptations that occur as a result, so what we do is we take this end systolic pressure volume relationship, and we plot that out here over varying pressures, and you can see we have a nice linear line here for the end systolic pressure volume relationship at varying volumes, and you can see that this line is of course relatively steep, right? So we can have a relatively large change in pressure resulting in a relatively small change in volume, and of course that's critical because then beat-to-beat modulation of cardiac output, you don't want to have massive variance in the stroke volume that is being pumped out of the heart. You want to have that be relatively small, and subsequently these changes in wall stress, because of the relatively low compliance during the contraction phase of the ventricle, and the thickness that is occurring at these relatively low operating cardiac volumes and short operating volumes that end up in thickening of the ventricle. So those serve to offset increases in tension that are being experienced, and stress in the wall that are being experienced by an increase in pressure. Now, reciprocally, when we look at the end diastolic pressure-volume relationship, this is relatively flat over here. So we can have a really small change in pressure on the y-axis and a relatively large change in volume. So there, if you end up having a very rapid influx of volume into the heart, you'd say, well, that's great. Let's start increasing cardiac output because we're obviously having some increase in volume, whether that's due to muscular contraction, promoting venous return, or whatever it might be. That's going to enable you to rapidly fill the heart and ultimately have the Frank-Starling mechanism mobilize that blood in an anterograde fashion to increase cardiac output in a relatively short period of time. So again, if we're looking at left ventricular end systolic pressure increasing suddenly, that's going to result in a subtle increase in left ventricular end systolic volume. You're going to have an increase in left ventricular end diastolic volume during the subsequent diastolic phase, because if you recall, the output of the right ventricle is going to be similar to the output of the left ventricle, and we've got the pulmonary circulation with a relatively constant amount of venous return over the course of a handful of cardiac cycles. So if you bump up that end systolic volume a little bit, then it's going to fill proportionally higher based off a constant venous return or pulmonary venous return, and that will result in that increase in end diastolic volume during the subsequent diastolic phase. That will increase stroke volume during the subsequent systolic phase via that Frank-Starling mechanism, and this is, in fact, the mechanism whereby we have intrinsic maintenance of left ventricular volumes. Not so dissimilarly, again, if you were to have a reduction in left ventricular end systolic volume, again, then you would have reciprocally a reduction in end diastolic volume. You have a reduction in stroke volume during the subsequent systolic phase, and with a constant pulmonary venous return, then again you would end up having a relatively higher filling over the subsequent cardiac cycle, and that would enable you to have again reciprocal maintenance of operating cardiac volumes. So when we're looking at this illustration now of how we have responses to increases in preload, these intrinsic responses that are regulating operating cardiac volumes, that's depicted here. So you can say, well, here's our normal pressure-volume relationship. When we end up having an increase in preload, now what we will have is a larger stroke volume here. So the difference between end diastole during one beat to end systole, so that is your stroke volume or amount of blood pumped out per beat. And the critical part of this is that since this is part of the intrinsic regulation of operating cardiac volumes and the Frank-Starling relationship, increases in preload do not alter the slope or positioning of the end systolic pressure-volume relationship. They solely alter the manner in which the ventricle is going to respond to an increase in preload. So that will increase stroke volume during that subsequent beat. Now, again, if we look at it, the response to an increase in afterload, you can see here that, again, the purple being normal conditions, if we have a very sudden increase in afterload at a given level of preload, then what will happen is we will have, again, increase in pressure generation during that subsequent systolic phase. That is going to increase further during systole, but then we're going to hit this point, this end systolic pressure-volume relationship, which physiologically the ventricle cannot pass that end systolic pressure-volume relationship for any given level of cardiac contractility. And then that will follow this down until you hit the point at which ventricular pressure drops below aortic pressure and go through isovolumic relaxation. And during that subsequent beat, assuming that cardiac, that pulmonary venous return is the same and cardiac output is relatively constant from beat to beat, then what you would have would be actually a greater filling of the ventricle during that subsequent beat. And that would serve to help offset that increase in afterload and maintain stroke volume during the subsequent beats. Okay, but most critically, from this diagram, what you should be taking away is that you will never be exceeding that end systolic pressure volume relationship for the left to right ventricles. So now you say, well, okay, so hopefully the intrinsic regulation of myocardial function and ventricular function is becoming clear. But then the question is, well, how are these pressure volume loops altered by changes in contractility? And so when we're looking at the definition of contractility, that's going to be the ability of a sarcomere, of a cardiac sarcomere, to produce force at any given level of stretch. So if you think of the diagram we had before, we were altering the level of stretch and showing that the more stretch we have on a cardiomyocyte, that we will have a greater sensitivity to calcium at any given level or at a higher level of stretch. Whereas now we're saying we're holding that constant, right? So we're holding our length constant. How do we increase the amount of force that can be generated when our length is constant? And that, when that changes, that is a change in contractility. And so that's dictated by something called the inotropic state of the heart. And so if you have a positive inotropic stimulus, that is something that increases contractility. If you have a negative inotropic stimulus, that's something that is going to be decreasing contractility. And so when you have positive inotrope, again, any level of length, any level of preload, you will have better function. With a negative inotropic stimulus, any level of stretch, any level of preload, you will have a lower degree of contractility or tension generation. And what that manifests as physiologically is as a shift in the Frank-Starling curve with these positive or negative inotropic stimuli. And so again, what we've got on the x-axis is left atrial pressure. You could say, well, this is our surrogate at this point, assuming that's representative of some change in volume or some appropriate change in left ventricular preload and or wall stress. You can see that with increases in left atrial pressure, that we have progressive increases in stroke work or stroke volume that are going to be manifested in the subsequent beats. But when you have normal conditions here, you can see with the positive inotrope, now you can see that at any given level of left atrial pressure, that we will have an increase in the amount of work that can be performed by the left ventricle. Okay, so that is what a positive inotropic stimulus, a stimulus that increases contractility, will do. If we have a negative inotropic stimulus or a negative inotropic pharmacological intervention, that at any given level of left atrial pressure, there would be a smaller amount of work that can be performed by the left ventricle. And of course here, what is largely being depicted is for example, progressive increases in sympathetic stimulation. So sympathetic stimulation is that fight or flight response with the autonomic nervous system, where you're going to try to be increasing cardiac output as rapidly as you can and as robustly as you can. That is a positive inotropic stimulus for the cardiac tissue. Increases in norepinephrine levels, increases in binding to beta adrenergic receptors that we discussed previously, increases in calcium-induced calcium release, all driving a positive inotropic response at any given level of preload. So again, if we look at this in a bit of a different way, the critical thing to look at this now, to think of here, is that, again, we're at a constant level of preload, right? So a constant level of ventricular wall stress and diastole. And so for that level of preload as depicted here, now, since there is a leftward shift in this left ventricular end systolic pressure volume relationship, you can see that at this given level of preload, what we will have is a larger stroke volume, right, for any given level of preload. So now if we take a look at some of the other permutations or variations that can occur with some of these pressure-volume relationships, certainly we've spent a lot of time thinking about contractility and changes in the inotropic state and the intrinsic state of the ventricle and how those are manifest here. But there are also many other disease states which can be depicted appropriately and very very insightful for understanding further with the cardiac responses to those various stressors. And so, if we take some examples here, so we've got one where obviously we've got the normal pressure volume loop here and a very deranged pressure volume loop depicted in the red. You'd say, well, what condition is going on here? And so if we start to break this down, you say, well, first, we've got a relatively low stroke volume, but second, we've got a massive systolic pressure being generated here. And when we look at both the isovolumic relaxation components as well as the isovolumic contraction components of this curve, they're still vertical here. Okay, so it looks as though the valves are still functioning appropriately. It's just that we're generating a tremendous amount of tension and pressure during that systolic phase. And so here, the condition that this is largely depicting is aortic valve stenosis. Second example here is going to be, again, let's break this down. So we've got our normal curve here in the red. You can see that we've got a relative reduction in preload. We've got a relative reduction in stroke volume. Both are end diastolic isovolumic contraction and diastolic and systolic isovolumic contraction components here are both vertical again, so it appears as though the valves are functioning relatively appropriately, or at least they're closing appropriately and coapting appropriately. But we've got this reduction in diastolic volumes here, and so think, well, what could possibly be a contributor to this? And this would be an example of potentially of mitral stenosis. So here you can have reductions in left ventricular and diastolic pressures as well. You can have the condition with left ventricular suction where the ventricle is relaxing and the mitral valve is so stenotic that it's actually sucking blood into the left ventricle, creating even a negative pressure there. So this would be a potential example of the manifestations of mitral stenosis. Now, when we start to look at some perhaps more aberrant changes in the pressure-volume relationships in this particular depiction, again, our normal pressure-volume relationship here in the open circle. Now, when we're looking at this very large pressure-volume relationship, you can see that we have substantial curvature and non-parallel, non-vertical isovolumic relaxation and isovolumic contraction phases here, so it's much more smoothed out. And in this instance, this would be an example of aortic valve regurgitation. So of course we have very high operating cardiac volumes and very little isovolumic relaxation. The reason for that being is that when the ventricle starts to relax, the aortic pressure is very high, and if you have regurgitation and incompetence of the aortic valve, then you're going to have a jet of blood coming back from a relatively high pressure system back into the ventricle, really forcing the dilatation of the ventricle and relatively high left ventricular pressures during diastole and failure to have a nice smooth and vertical and diastolic and isovolumic relaxation phase here, because you're going to have that regurgitation of blood back into the ventricle. Now finally, with our last example here, again, we have a very large pressure-volume relationship here in the pathological condition. Again, we have the smoothing and non-vertical nature of the systolic isovolumic contraction phases and the diastolic isovolumic relaxation phase. So it's not really isovolumic anymore. Fundamental difference here being, of course, when we look at it compared to our previous one, well, we said, well, here we have a relatively, not a normal, but, not a very low left ventricular operating volume during systole, whereas it is substantially lower here in this example. And so this would be an example of mitral valve regurgitation. And so in early stages of mitral valve regurgitation, what you'll have is a low left ventricular end systolic volume. That is because as the ventricle contracts, instead of having all of the blood go anterograde and go out of the aortic valve and push that mitral valve shut and enable all the blood to go anterograde through the aortic valve, now there's regurgitation and incompetence in that mitral valve. So instead of pumping all the blood out anterograde into a relatively high pressure system, it's starting to pump some blood out into that high pressure system, but it's got a leak back into a relatively low pressure system. So what that will do is that will allow you to actually go down to a lower end systolic volume, because it's actually technically reducing afterload due to that lower pressure and that outlet into a lower pressure system. Now, of course, over time, there's generally loss of that compensation there. Of course, even in a relatively short term, you'll actually you'll have a hyperdynamic cardiac condition, because you're going to have tachycardia or rapid heart rate, because every time the heart beats, it's pushing blood forward, but it's also having some of that blood go backwards. So then the autonomic nervous system is going to say, hey, we're getting signals from all over the place that you're not perfusing exactly how you should be. So let's increase the contractility, let's increase the rate of contraction in an attempt to try to match nutrient supply with metabolic demand. So to close the rest of this lecture today, the couple of questions that you might have is, well, this is interesting and all, but for example, how am I going to measure, or how can I measure volume in the left ventricle and the right ventricle? And of course, there are many imaging modalities to do this. So one of course is 3D scanning with manual or nowadays augmented segmentation. So again, here with 3D CT scanning, it really doesn't require a whole lot of faulty assumptions regarding left ventricular geometry. It doesn't assume that the ventricle is a radius. It actually goes through and takes the slices and says, well, we know the geometry of the ventricle now, and we can solve with reasonable accuracy the volume within the left ventricular cavity, or the right ventricular cavity for that matter. There are methods where you can use conductance catheters, which have been used extensively in experimental animals, where CT scanning often can be very challenging. And so their conductance with the appropriate calibration does translate to a change in volume. And of course, this is built on the fundamental assumption that as you go down with each one of these conductance measurement points, is that you're solving for the volume of a cylinder, which again is not certainly a perfect assumption for the left ventricle, or certainly not for the right ventricle, which is more crescent-shaped. But it can provide an estimate, most often, of left ventricular operating volumes. Now, when you're looking at measurements that are, again, much less invasive than a conductance catheter, or much perhaps more high throughput and easier to administer than a CT scan, you can use two-dimensional or three-dimensional echocardiography with manual or augmented segmentation of the ventricle. So, of course, with two-dimensional echocardiography, you're largely looking at making some critical assumptions about the geometry of the ventricle and how you're going to solve for volume. With three-dimensional echocardiography, you can reduce many of those assumptions quite significantly. And here you can see that there's the model of that is elicited, it's produced from the segmented images, and that's done from a 4-chamber, 2-chamber, and 3-chamber view of the ventricle and heart. You can also measure volume using radionuclide ventriculography. Again, here, many challenges associated with doing this. I mean, first, of course, you have to give a radionuclide. You have to have a measurement strategy for taking that measurement. You have to control for attenuation coming out of the chest. But if you can make all those assumptions appropriately and make your measurements accurately, you can get an estimate of operating cardiac volumes using gated image scanning and the radionuclide ventriculography. And so, collectively, we've got multiple methods and some of which have advantages and some of which have significant disadvantages and limitations to measure changes in operating cardiac volumes over the course of a cardiac cycle and ultimately estimate how the ventricle is adapting in response to various stimuli or changes in contractility or the intrinsic state of the ventricle. So at that point, then we say, okay, well, where does all this blood go, right? So this blood goes out to the body, goes out to the lungs, goes back to the heart. So what we're going to start to do now is incorporate some of the peripheral vascular changes and the implications of changes in the vasculature with the function of the central circulation, and hopefully start to pull this together in a more integrated fashion as we start to move out of the ventricles per se and start to incorporate some of these interactions with the systemic vasculature. So collectively, just to summarize what we covered today, we've got the Wiggers diagram. Of course, it's very useful to depict changes in cardiac pressures, volumes, and sounds, again, being depicted over time. We have the Frank-Starling relationship, Frank-Starling relationship being critical determinant of intrinsic regulation of cardiac volumes. The pressure-volume relationships being very important and useful for understanding changes in cardiac function. And again, a really drive home point here being is that the principle of wall stress, we would argue, needs to be accounted for when you're examining the Frank-Starling relationship as well as pressure-volume relationships, because otherwise there are too many changes that can occur physiologically that ultimately influence the interpretation of your data and really can have you draw some flawed conclusions, despite the fact that outwardly it might look as though you're making the right measurements. It's just that you're not interpreting the entire data set appropriately. So with that, we will stop there, and we'll look forward to seeing everybody in the next class period. Thank you.